Hello and welcome back. This is New York Medical College, Touro University's online program, 90 Minutes, the medical magazine of the web. We want to welcome you to webinar number 29. Yep, 29. This is our 4th anniversary of doing these programs. We started around January of 2020. My, how the time flies. 29 of these programs. We've been averaging 7 of them per year. We started out focused on COVID-19, then we morphed into this general medical magazine of the web to bring you up to date on what you need to know about medicine, healthcare public policy, and what you as clinicians or patients ought to know about developments in medicine. Now, last time we were here for webinar number 28, we had a program called Ouch, This or That Hurts, and what are we going to do about it? It seemed to be such a hit that we've decided to do another themed webinar, and this one is all about what should I do? Current controversies in medicine. So we've got a lineup of some of your old friends and some of your new friends. We're going to start with our #1 fan favorite. Yep, Dr. Marissa Montecalvo is back, and her topic for this webinar is, what should I do? My friend and I are both over 65. My friend's doctor told her to get the RSV vaccine, but my doctor said I shouldn't. She's going to explain it all to us. Then we've got someone you have not met before on the webinars. It's Dr. Michael Liu from the Touro University College of Pharmacy. And he's going to talk to us about all of those advertisements you get about how to get your prescriptions for some by-the-mail pharmacy at a discount. Recently, I went to one of my doctors, and right there on the reception desk, there are these little plastic cards. You can get your prescriptions from this company. We may not even use your insurance. I looked up the prices of some of my medicines. They were going to charge me $3 for a 3-month supply. You wonder whether it's even worth sending out a bill for $3. But his topic is, what should I do? I've been getting my prescriptions through the mail from my insurance provider, but now there's online companies that say they can supply my medications more cheaply. Our third speaker today is someone who's been with us many times before. Dr. Anitha Srinivasan is back from Metropolitan Hospital Medical Center and the Breast Clinic. Her topic is, what should I do? More and more women are being diagnosed after a mammogram and a biopsy with a small focus of ductal-carcinoma-in-situ of the breast. But there's some people who say we should stop even using the word carcinoma for this diagnosis because it prompts over-treatment. What should we do? This is an increasingly common problem. When I was a young doctor, we very rarely saw ductal carcinoma-in-situ. Now it's a very common diagnosis, and I've seen women suddenly insist they want bilateral mastectomies for a diagnosis which in many people is not a disease. Not everybody who has a diagnosis has a disease. They will not be diseased by the diagnosis. Dr. Srinivasan's going to walk us through that. Our last speaker is going to be Dr. Morgan Stoffler from Westchester Medical Center and the Department of Medicine of New York Medical College. And this is another common problem. What should I do? My spouse snores. And when I wait on that TSA line at the airport, it looks like half the world's traveling with a CPAP machine. Should I send my spouse for a sleep study and get one of those machines? And maybe both of us will sleep at night. Well, she's going to walk us through that issue, and we'll learn all about sleep studies and CPAP machines and snoring. Now, as always with these webinars, if you're looking for continuing medical education credit, I will appear in between the speakers to tell you how to get it and give you the phone number to use for your text messages or the QR code. And if you have any questions for any of our speakers at our program today, please type them in the Q&A box on the bottom of the top of your screen, depending where your software puts it. And we'll get to as many of the questions as possible during our question and answer session, which will be moderated by the president of Touro University, Dr. Alan Kadish. So welcome to webinar number 29, and let's get started with our first speaker.
Good afternoon. I'm Marissa Montecalvo, and I'm speaking on respiratory syncytial virus vaccine, trying to explain to you why there are discrepant recommendations regarding receipt of this vaccine. I have no conflicts of interest to disclose. The objectives of this talk are to understand the current recommendations for receipt of the vaccine and why these can lead to discrepant recommendations, and to understand the data leading to the vaccine approval. So let me just begin with the virus itself. What exactly is respiratory syncytial virus? So it is an RNA virus that infects both the upper and lower respiratory tract. Humans are the natural host, so it is spreading to humans by person-to-person transmission. And the season for RSV is actually quite long. It can be just about half the year. These are data from CDC looking at laboratories that do surveillance for RSV, reporting either on positive antigen or PCR. And you can see last year that it started in September, peaked in December, and was down by February. And this year we started a bit later. So this virus, which is an RNA virus, has a surface protein called the F surface protein, which is important for viral attachment. And it is that protein that the vaccine is targeting. So vaccines are always targeting some protein. So what the vaccine does is it's producing antibody against the F protein in the form that it is just before attachment normally would occur. This virus spreads usually by large particles because there's a lot of respiratory secretions associated with this infection. Respiratory secretions are heavy and they fall to the ground, usually in close proximity to where you cough or sneeze. So it is being spread in theory by close transmission within a couple of feet. But unlike some other respiratory viruses, it does have a significant environmental component in that surfaces become contaminated and can be a source of spread. Incubation period starts short, 2 days, but can go out to 8. And once infected, you can shed virus for 7 to 10 days. Respiratory syncytial virus is predominantly a disease of infants. It causes lower respiratory infection, bronchiolitis, which can result in hospitalization, predominantly in the first months of life. Disease can be very severe in premature infants or infants with cardiopulmonary disease, and most severe after that first infection. But if the baby has risk factors for severe disease, can also be can result in hospitalization on a second infection. You produce an antibody response, but it's incomplete. So what do we do for infants? There have been many treatments that have been looked at over the years, but currently the recommendations are to give the infant either a monoclonal antibody if they are within the first 8 months of life during RSV season, or we can vaccinate pregnant women who are in their third trimester, specifically 32 to 36 weeks during RSV season, so they can transfer protective antibody to the infant. So these are data of hospitalization. This happens to be this year, but it is similar looking back. And the purple are the 0 to 4 age group, but here's the over 65. So you can see in blue the increase compared to other adult ages. So this over the years led to trials of RSV vaccines in adults. and those trials were done in persons 60 years of age and over. There are 2 vaccines, one produced by GlaxoSmithKline, the other by Pfizer. The Pfizer vaccine is the same vaccine that is administered to pregnant women. These vaccines were compared in phase 3 trials against no vaccine, and the outcomes that were looked at were lower respiratory tract infection, which was reported by the person in the trial based upon their symptoms, and then they would be tested, and then if positive, that it would count, or a medically attended lower respiratory tract infection. They also tried to look at hospitalization, severe disease, and death, and as with any vaccine trial, looking at immediate and long-term adverse events. This is just an example of the design. It happens to be the Pfizer trial, and I wanted to show you this just so you could see. Here's vaccine or placebo administration. This is the follow-up for safety, but these trials went over 2 RSV seasons, looking at protection across the first as well as the second RSV season. So what were the results? Starting with GlaxoSmithKline in Table 1, protection against lower respiratory tract infection for season 1 was 82.6, combined across the 2 seasons, 74.5. For Pfizer, the numbers were slightly higher, but again, this is protection against reported lower respiratory tract symptoms that then tested positive. Safety was pretty good. There were about, some severe systemic reactions. And interestingly, there are 6 cases through these 2 trials of an inflammatory neurologic condition, some of which is Guillain-Barré, some of which is similar to Guillain-Barré. Those numbers are a little higher than spontaneous inflammatory neurologic conditions. So all of this led CDC to make a recommendation in June for adults 60 years of age, given that the efficacy was quite good, to receive RSV vaccine, but using something called shared clinical decision-making. So what is shared clinical decision-making? Well, it's something that pops up now and then in vaccination schedules. I'm showing you here the adult vaccination schedule for a few respiratory vaccines. Yellow is something we give, is recommended for everyone, so that would be COVID-19 and flu. Purple is with a risk factor, so this is RSV during pregnancy, with pregnancy being your risk factor. And here's the shared clinical decision-making for those 60 years of age and older for RSV. So what is shared clinical decision-making? It is looking at the risk factors that someone may have for a disease, but it's more than that. It's looking at the potential for underlying conditions. Maybe you're in a socioeconomic group where your potential for comorbidities is higher than others, even though you may not have a particular condition right now. Or maybe you pick up a child from daycare, or you have grandchildren. These are all things that would play into a decision as to whether you should receive RSV vaccine. Why did they go this route? They went this route, I think, for several reasons. First of all, there were limitations to the efficacy data. The numbers look good, but the definition of what qualified for lower respiratory tract infection was actually not the same for the 2 trials. Those who received vaccine, the comorbidities were low. So when it came to looking at things like hospitalization and severe disease, the studies weren't large enough to actually have any conclusive data in those areas. The second point, I think, is one of the things that really led to the shared clinical decision-making as well. So the efficacy in the 60 to 64 was not quite as high as it was in the over 65. However, there are data that comorbidities in select populations really differ based upon race and socioeconomic situation in the 60 to 64 age group. So when they looked at all of this, they didn't want to withhold vaccine from the 60 to 64 group because there are people who might benefit there. And that led also to the shared clinical decision making. As I mentioned, there are a few safety concerns. It's not anything, really very large, but I think, they want more data. And it also is worth mentioning that RSV vaccine has been studied, co-administered with influenza, and there are no issues with that. So I just want to say another word about shared clinical decision making. This just looks at whether physicians really like this. So on the one hand, it gives you flexibility, as is shown here, but on the other hand, shared clinical decision making means taking time to really discuss whether this is something that someone should receive. And some offices are not set up for that. I mean, some offices, you get your vaccines at the end of the visit and it's either yes or no. And some physicians may just feel, so look, if it's not a hard and fast decision, there's too much that's ambiguous here. I'm just not going to recommend it. Or there isn't enough for this one patient. So in conclusion, the reason some doctors recommend RSV vaccine and others do not is because I think of the shared clinical decision-making recommendation. I do want to mention that there are other vaccines that have gone this route. Hepatitis B vaccine and diabetics started as a shared clinical decision-making. Currently, human papilloma vaccination for those 27 to 45 is a shared clinical decision-making vaccine because risk can vary in that age group. So shared clinical decision-making, as I said, it's risk factors, but it's more than that. There are components of potential comorbidities as well as lifestyle that are important to incorporate. And the current recommendations, the current data weren't strong enough to go further. But usually what happens with shared clinical decision-making is over time, a recommendation becomes clearer, but that time frame can be quite long. And it is likely that that may happen over time with RSV vaccine. These are my references, and I look forward to your questions. Thank you.
Hello again, this is your host, Dr. Edward Halperin, with some information for those of you who wish to get continuing medical education credit for attending today's webinar. We have two options for you to get your CME credit. You can send a text message to the phone number 828-295-1144 and text the code 30WIRE, all in capital letters, W-I-R-E, 30WIRE, to that phone number, and you'll get a message back which will explain to you how to fill out your satisfaction questionnaire and how to get your CME certificate. If you don't want to do it that way, you can take out your device with a QR code scanner and scan that exotic looking quasi chessboard on the side of the screen, and it will instantaneously take you to the website to fill out your satisfaction questionnaire and to get your CME certificate. Now, these techniques will be active until 12:30 in the afternoon on Monday, February 5th. So let me recommend that you either take a screenshot or you write this information down, or you go ahead and do it so that it won't expire and you can get your CME credit. As we always say during these webinars, if you have any questions for our panelists, please type them in the Q&A section on your computer screen. And when we get to the Q&A part of our program hosted by Dr. Kadish, we will get to as many of your questions as possible. And now let's get back to our program.
Hello, everyone. My name is Michael Liu, and today I'll be talking about what should the patient do if, let's say, they get medications perhaps online more cheaply with or without the insurance. I don't have any conflict of interest in regards to this presentation. Here are the learning objectives of the presentation, which I'll be going over throughout the presentation. Brief background information. In 1946, the VA had their first pharmacy dedicated to fill a prescription medication delivered to their patient's home. As of 2023, the VA still accounts for 1/3 of these mail order pharmacies. Please note that mail order does not necessarily mean the same as online pharmacies. So mail order operate through the patient's health plan and through the pharmacy benefit manager or the PBM. An issue can arise if the PBM is owned by the pharmacy, and also if the Aetna is owned by the pharmacy as well, the insurance plan. So for example, if CVS owns Aetna and the PBM is owned by CVS, you will see that Aetna might tell their patient to go to CVS to fill their prescription, and then this could be a conflict of interest in terms of drug pricing. Online pharmacy is the purported solution to this, that first off, they don't partner with large PBMs, insurance is not required, and there's pricing transparency of the costs, pharmacy labor fee, markup, shipping costs, so on and so forth. However, this is dependent on you trusting the company giving you that transparency data. This shows you the rise of prescription drug delivery by mail. In the US, the y-axis corresponds to estimated number of people in millions. The x-axis corresponds to 1998 to 2017. Overall, you see it essentially slightly double from 12 million to 26 million during that time period. If we look at the impact of COVID on weekly mail prescription from January to July of 2019 in black versus red in 2020, you can see that during the pandemic, there was an increased demand for prescription delivery by mail significantly, especially during the height of the pandemic. This shows you the prescription drug business to consumer or B2C process. The top shows you the payment, who are the ones that are eating the bill. In this case, the plan sponsor, the employer, and the patient. And who benefits from the profit includes the pharmacy, wholesaler, drug maker, and the PBM. Note, again, the PBM is supposed to decide who gets a slice of the profit and is supposed to look out for the best interest of everybody. But if the pharmacy owns the PBM and the pharmacy owns the wholesalers as well as the insurance company, you can see that the patient ultimately will not benefit from this overall. And if you look at the figure at the bottom, you can see the different supply chain link for drugs, prescription drugs, and you can see that at the bottom left-hand corner, the third-party PBM is involved financially in all these, and it's the critical link in the supply chain process. There are 3 problems with delivery by mail. First is the wholesaler safe? You can see the pictures of mold that perhaps people make to make false drugs. There was a Xanax that was tainted with fentanyl and caused numerous deaths. Canada Drugs was accused of making improper counterfeit drugs. You can prevent this by verifying it with FDA's BeSafe RX or even through your state board of pharmacy. And this is essential because overdose deaths across the US have continued to increase even to this day. The secondary problem, it has to do with the delivery integrity. This is no different from food being delivered to your home if you have that service. Is it delivered in the right condition? Has it been refrigerated? How long has it been sitting out for? So on and so forth. There are multiple mechanisms to prevent these, to improve the integrity. For it to happen, you have real-time delivery tracking, narrower delivery window, remote monitoring. However, the problem with these is obviously how feasible and expensive this is. What happens if it has been sitting out, let's say the integrity has been compromised, what should the patient do? And how would the online pharmacy deal with the costs? And obviously, there's also a human element to it because no matter how well you plan this, perhaps the delivery is late because of traffic, the truck breaks down, the individual steals the product, neighbor steals the product, who knows? There's also a lot of variables involved in proper delivery integrity. What is most important for this talk, perhaps, is really the complexity of assessing true cost savings. When you shop around, you increase the risk of your drug profile being incomplete. You also increase the risk for errors. Do you really save money and do you really save time by shopping around? What kind of insurance do you have? If you have a 30 versus 90-day supply, what if you have a change in dose because of something acutely happening? What if you need to change your drug altogether because you don't tolerate it, and now you have a 90-day supply sitting with you? Do you mail it back? Do you throw it out in the garbage? What is the proper way? Whereas you can't really go to your pharmacy and drop it off, because that's not where you got it from necessarily. So what should you do? There's lots of questions with that. And for online pharmacy, there's multiple issues. There's membership costs, shipping costs. Do the online pharmacy carry everything you need? Does it even ship to where you are? Does it have complementary products? And because of these online pharmacies, there's more and more propping up, so to speak, and more competition, volatile pricing can occur. So even if, let's say, you determine through all your efforts that you're saving money now, that might not be true a month or two from now because of the volatility involved. These are some examples of online pharmacies. You can see on the upper left-hand corner, for example, Amazon does not ship to Hawaii. There's 139 annual membership costs. If you look at right next to a health warehouse, it ships to all state. But again, there's hidden fees not necessarily presented here, such as shipping costs. You don't know how much it costs. If you look at the bottom right-hand corner, Scriptco has the least expensive of these common medications, but it does not ship to 4 different states as of this time. So overall, what should we do? What is my recommendation of what is presented? First off, is there true difference in mail order versus online pharmacy? They purport to be different, but is it really that different? It's questionable. Here are the ideal candidates for prescription delivered by mail. As you can allude to, perhaps the VA patient fits the bill, chronic disease, stable condition, significant mobility limitation. So again, those are the patients perhaps most best will fit this as a good candidate. The patient or caregiver needs to be very vigilant on delivery and contingency planning. So if the integrity has been compromised, or if the medication didn't deliver, or is missing, or there's dosage change, they should be vigilant on how to handle this situation with the online pharmacy or mail order pharmacy. Overall net savings were difficult to assess. It should be assessed by individual basis. There's too many independent variables. As I mentioned to you earlier, is very volatile. But if there's one message that I would say is crucial, is that if you do shop online for the different pharmacies, whether it's mail order or online, try to avoid using too many pharmacies. It adds confusion. It increases risk for errors. You're not saving time. You probably won't save money because of the switching costs of the membership costs and all these other items. So even if you do try it, try to limit it to 1 or 2 perhaps. Thank you for your time, and I'll address any questions you have.
Hi again, this is your host, Dr. Edward Halperin, explaining how you might give back to New York Medical College, because programs like we're putting on today and research projects, which we talk about, require time and effort and money. By making a tax-deductible gift, your donation will help offset our costs. Now, great things are happening in New York Medical College. We hope you'll be a part of it. You can visit a website, www.nymc.edu/give, to make a donation. Other ways you can make a donation to support this webinar is we have real people who answer the telephone. You could call 914-594-2720. And they'll be more than happy to take your credit card information over the phone if you'd like to make a tax-deductible donation. As I said, you can use this website, www.nymc.edu/give, to make a donation to support this webinar and our research. Or if you believe in pens and checks, we take those too. You can make a check out to New York Medical College, write on the memo line of the check, support for the webinar, and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us. Thanks for supporting these programs. Remember, if you want to ask a question of any of our panelists, go ahead and type it in the Q&A box on your screen. We'll get to as many as possible during the Q&A part of the program. Stay safe, everyone. Stay healthy, and let's get back to our show.
Good morning. My name is Dr. Srinivasan. I am at Metropolitan Hospital, and I'm a faculty of New York Medical College in the Department of Surgery and teach medical students. Today, Our topic is DCIS, or ductal carcinoma in situ. The question I am to address is, what should we do? DCIS. More and more women are being diagnosed after a mammogram and a biopsy with small foci of ductal carcinoma in situ of the breast. But some people say we should stop using the word carcinoma because it promotes overtreatment. I have no disclosures for this discussion. First, let's start off with the very basics to understand where this cancer or this ductal carcinoma in situ is going to arise. So all breasts have the following components, which is a duct, a lobule, and particularly a dilation called the lactiferous duct, and then the terminal duct lobular unit, which then goes out and branches into stroma. And all the ducts finally converge at the nipple areola complex and drain through the nipple. And the most common cancer still remains ductal type of cancer. And it is actually invasive ductal cancer. So what is ductal carcinoma in situ? This is a condition that we got to know about in the late 20th century as a non-invasive form of a carcinoma of the breast. Because it was not previously diagnosed on screening studies or imaging, most of the time historically when we found this disease, we found it as a palpable lump, and it had features called comedo necrosis, and hence was called comedo cancer. Now, as our screening evolved, we got better with imaging, we started detecting more and more of these type of cancers in biopsies and excisions, which are basically limited to the inside of the duct and not actually spreading outside like cancers spread widely. So they are limited by the basement membrane of the duct, hence the name ductal carcinoma in situ. We further got to know that there are subtypes in this ranging from very aggressive histological features like necrosis and papillary types, cribriform types, and so on and so forth. So there are now histologic subtypes. So this itself became a whole topic to discuss and follow. And then we started getting interested in the natural history of DCIS. What do I mean by the natural history of DCIS? So we now have normal breast epithelium, which then becomes atypical or atypical breast hyperplasia. Sometimes we find these in biopsies. And these can then progress to ductal carcinoma in situ, which can then progress to invasive ductal carcinoma. And of course, if untreated, the invasive ductal carcinoma can become metastatic, causing death, like any other cancer. Now, what we aim to do as breast surgeons, mammographers, primary care physicians, and a healthcare provider is identify this before it becomes this, meaning we do not want to diagnose breast cancer at a later stage. So DCIS is a very, very early stage, or in some people's words, a precursor to actual cancer. Does this make it a non-cancer? It is still to be decided, and it's still being argued among academic and practicing circles as to what do you do with a diagnosis of DCIS in today's day. We've got to know a lot about it since the days we initially understood it. We also knew that autopsy studies showed that women died with undiagnosed DCIS that didn't cause them death. However, the problem now remains, what do you do when you have a biopsy that shows DCIS? Do you tell the patient you have cancer? Do you tell the patient you have a precursor of cancer? Or do you tell the patient you just have some changes in the biopsy And I don't think you need to be worried. Now, just like the conversation is along a big spectrum, the understanding and the treatment also is a big continuum or a spectrum of the disease itself. The problem is less than 10% of the women with DCIS will actually develop invasive cancer. Does this mean we don't pay attention to that 10%? No, we have to. That's a significant number. And the biggest problem with DCIS is you don't know which features of a DCIS actually predict that 10%. Meaning, if I have 10 patients with DCIS, how am I going to say which one of them is going to be at risk for invasive cancer progression? Not always do we have this serial linear following. The problems are multiple. You could have atypical ductal hyperplasia because we biopsy almost all breast cancers with a small needle using a stereotactic vacuum guided, image guided biopsy, meaning we put an ultrasound, we put a needle in, we take out that area with the calcification. Usually when you have DCIS, it should be detected before it becomes palpable or a big lump. So we identify it, we rightfully biopsy it. Now, the question becomes, have you biopsied all parts of this lesion? Have you missed a part that may have more than atypia, more than ductal carcinoma-in-situ? So what does that mean? Ductal carcinoma-in-situ exists, but it can coexist with invasive cancer, meaning it could be a sampling error where you just picked up the ductal carcinoma-in-situ. So how do we avoid this? Well, we try to image guide it so we get multiple takes, and we try to cover the lesion as much as possible. We leave a clip in there, we follow up, and so on and so forth. There are methods to do this. Now, having said that, what else can we be missing here? Can we then be missing some features that tell us that this type or this subtype of ductal carcinoma-in-situ is at risk for progression to a bad disease? So the answer is yes. Lately, they have been classifying as ductal carcinoma low risk, intermediate risk, and high risk. This is purely histologic and by no means 100% classification. And the range is very, very wide, which then as clinicians presents another problem of what do we do with this diagnosis. Now we are looking very keenly at the following trials happening around the world in terms of just surveillance of DCIS. These are all randomized controlled trials that are being followed very closely. And we want to understand which of these patients do we actually have to treat and which of these patients can we avoid treatment in with surgical methods, and keep them non-invasive, just keep imaging them to see if this is progressing to something more dangerous. So we will be keenly looking at this, but we don't have a black or white answer from these trials. There is also some centers that are looking very cleanly at patient involvement, explaining the risk. It's called the Wisdom Trial at University of San Francisco, University of California, San Francisco, and they are basically discussing with the patients very honestly the risk of the type of DCIS they have and whether they want to be surveilled or do they want invasive treatment. Now, what does invasive treatment entail? We have to know the flip side of it. What are you avoiding and what are you benefiting from having the surgery? Invasive treatment for DCIS will include excision, meaning a lumpectomy. You will have to do the lumpectomy with margins. Now, the question then becomes, you have to finish the treatment with radiation. Like any breast surgeon will tell you, lumpectomy is incomplete without radiation. So how do we further decide who can avoid radiation? Now, there are categories in which radiation can be avoided in very low risk or suitable patients. Again, this is being studied, but you must aim to get clear margins. These patients might have a small tumor and histologically very low risk to progress to a bad invasive cancer. So where does that bring us now? As of now, I would say I would continue calling this a DCIS or an in-situ cancer. I would tell the patient this is a stage 0 cancer, which it is, and that the survival rates or the risk of dying from this cancer is almost negligible and close to 0. We don't anticipate this. Now, the flip side is Singapore did an interesting trial that said, what's the risk of dying if you actually do surgery on DCIS patients? It was again 0. There was one patient that died who had the breast disease and from a breast diagnosis, but it was an invasive cancer on the other side that became metastatic. So from the actual DCIS death rate, because of surgery is 0, but you can observe, hopefully we will get answers either about a marker or a particular histologic feature in future from these various trials saying this particular DCIS can be followed with imaging and does not need any surgery or invasive treatment. So we look forward to a day like that. So as of now, I don't believe we are over-treating. I think we do need to discuss the risks, benefits, and give the patients all the facts to decide if they want to be surveilled or they actually want the invasive treatment and let them decide. But that doesn't mean I would do a blanket statement of not calling this DCIS or a stage 0 cancer. And whether to observe or excise is a big question. Luckily, most of the DCIS in some of the studies have told us that the sojourn time or the time to invasive cancer is almost 2.5 years. So if you see something in imaging that is rapidly changing, then you have an opportunity to actually excise that area and continue with the treatment. If it does progress to invasive, also you have the opportunity to excise or do a lumpectomy and do a full treatment. Because remember, you never are losing track of the patient and you have to surveil them and image them serially. It is also up to patient anxiety because every time you leave a high-risk lesion inside and you bring them back for surveillance, there's a significant patient anxiety factor that goes into consideration. Some patients may just choose to have that area excised and have it fully treated. So it brings us back to the question of, yes, I would continue calling this DCIS. I would have a very open discussion with patients, offer them the options. How do we actually diagnose this? We still follow this classic BI-RADS criteria in a mammogram, and we do a sonogram to detect whether these have a lump in coexistence. And we can do MRIs, which used to be not so great in DCIS, but the technology has evolved a lot. It does overcall some areas, but we continue to follow the treatment of DCIS like it is a stage 0 cancer among breast surgeons. Thank you.
Hello again, this is your host, Dr. Edward Halperin, with some information for those of you who wish to get continuing medical education credit for attending today's webinar. We have 2 options for you to get your CME credit. You can send a text message to the phone number 828-295-1144 and text the code 30WIRE, all in capital letters, WIRE, 30WIRE, to that phone number, and you'll get a message back which will explain to you how to fill out your satisfaction questionnaire and how to get your CME certificate. If you don't want to do it that way, you can take out your device with a QR code scanner and scan that exotic looking quasi chessboard on the side of the screen, and it will instantaneously take you to the website to fill out your satisfaction questionnaire. and to get your CME certificate. Now, these techniques will be active until 12:30 in the afternoon on Monday, February 5th. So let me recommend that you either take a screenshot or you write this information down, or you go ahead and do it so that it won't expire and you can get your CME credit. As we always say during these webinars, if you have any questions for our panelists, please type them in the Q&A section on your computer screen. And when we get to the Q&A part of our program hosted by Dr. Kadish, we will get to as many of your questions as possible. And now let's get back to our program.
Hi, everybody. My name is Morgan Soffler. I am an assistant professor at New York Medical College and a physician of pulmonary critical care and sleep medicine. And I'm very excited to speak to you today about obstructive sleep apnea in 2024. I have no disclosures. So a common tale, this might look familiar to you, it certainly does to me as a sleep medicine specialist, is seeing patients who come in with their spouse because they're snoring too loudly and it's just wrecking their marriage, right? You might have friends or feel yourself, hopefully not, but people just can't get that good night's sleep. They're waking up multiple times in the middle of the night, never feeling refreshed, or just that sort of dragging feeling during the day, or especially during the time of Zoom, that feeling like you just can't make it through the day without a nap, or you're just kind of falling asleep all over yourself. And these are all different things that you may have heard yourself or experienced that make you think, do I have sleep apnea? Does my partner have sleep apnea? Does my patient have sleep apnea? And the answer is, there's a good chance that they do. So sleep apnea is really common. And in the clinical world, we're all seeing patients with sleep apnea. About 25% of all adult males, 9 to 13% of females in the United States have sleep apnea. And this is of sort of the people who are diagnosed, but we acknowledge too in the field that there are so many patients who are walking around with undiagnosed sleep apnea. Approximately 80% of all OSA patients are actually undiagnosed. And the WHO, the World Health Organization, estimates that there's about 1 billion people worldwide with obstructive sleep apnea. So this is a really, chances are someone and or have cared for somebody kind of in the clinical realm who's had obstructive sleep apnea. And I would say that in the last decade, there's so much exciting things that are going on within the field of sleep medicine. And number one is our understanding about the causes of sleep medicine. Kind of the classic vignette is somebody who's overweight, has a large neck, and that has just this anatomical obstruction to airflow, which you can see in the diagram here, where there's either a partial or full obstruction as the tongue and all the soft tissue and soft palate kind of collapse during sleep. But what we know now is that there's probably a lot more to the story. So while anatomical compromise, or just that sort of frank mechanical obstruction, does play a major role for the majority of patients with obstructive sleep apnea, there's other factors too, things like impaired pharyngeal dilator muscle function. We have dilator muscles within our in our pharynx that are meant to kind of deal with some natural obstruction and dilate. But for some, those muscles are just lazy and not working properly. There are people who just wake up really, really easily, and that contributes to kind of ventilatory instability and obstruction and kind of those muscles not being able to function as they should. And then there's others that maybe just kind of their peripheral chemoreceptors in their brain doesn't respond well to some obstruction, and they get just sort of this unstable ventilatory control that causes significant ventilatory instability as they sleep. And that's the major reason why, they're presenting with symptoms. So we know now it's more than just a large neck, right? There are different what we call endotypes of obstructive sleep apnea, which is where a lot of fields in medicine are going now, right? Not just sort of thinking about like a one-size-fits-all diagnosis, but what is really happening pathophysiologically. And so this is some really interesting work that's been done in the field. So taking us to testing for obstructive sleep apnea. So here I get to share an embarrassing photo of myself getting an in-lab polysomnogram, which remains the gold standard for diagnosing obstructive sleep apnea. And you can see here, we get lots of great data from a polysomnogram. We can look at sleep stages, oxygen saturation, body position, leg movements. This person, unfortunately, has a lot of kicking leg movements, and respiratory events, of course. So although this remains the gold standard, you might be finding in your practice that insurance is kind of moving away from in-lab testing. And this is really because our testing at home, which I'll mention in just a moment, has gotten so good and so robust. So this remains the most expensive option, typically covered by insurance, but you might find now that patients who have sort of an uncomplicated comorbid, don't have a lot of comorbidities, maybe kind of put on the path of a home sleep study test instead of an in-lab test. And just to give you a little bit of a breath-to-breath idea of when we kind of look at these sleep studies, how does that help us make kind of the clinical correlate to what's going on with the patient? Well, here at the top of the screen, you can see we have EEG data, which can show us that in response to these obstructive events, is the patient having arousals, which are there as kind of a protective thing to help resume airflow. And so a person who's having a lot of arousals related to their sleep apnea may report issues with memory, concentration, feel sleepy during the day, or have issues kind of with just feeling run down and have a poor quality of life. And then if you look towards the bottom of the screen, we could see the pulse oxygen saturation that decreases along with a decrease in airflow that we might see on a sleep study. And this tells us a bit about the gas exchange disturbance. And so, when the oxygen level goes down in response to an obstructive event, we get catecholamine surges, oxidative stress, inflammation, things that should not be around during a restful night's sleep and put extra strain and stress on the cardiovascular system. Okay, so the exciting bit here is that our technology in the last decade has really grown exceptionally for at-home testing. So in this picture here, you can see a woman who's having an at-home test, still relying on oxygenation and airflow to look at. So this is the most common at-home test that we'll see that most patients are referred for. But there's some new exciting technology that you may have also heard of that I want to just highlight for a moment. So here in this picture, you can see a woman with a watch-like device and an oximeter on her finger. There's a little something on her chest that looks at body position. And this is called a WatchPat device. And it works by analyzing peripheral arterial tonometry data. So what you can see here in this image is that during this apneic event, the patients, obviously, we're not measuring airflow, but the airflow is going down. This patient presumably had an arousal event that caused their sympathetic tone to go up and their endothelium in their fingers to constrict, which is why we see the decrease in the amplitude signal here and an increase in heart rate. And so with this data, we can confidently say that this patient had an apneic event. And we can even use peripheral arterial tone to evaluate sleep stages, which is something we couldn't really do with a conventional home sleep study test. This is something that is fairly widely available, that is often covered by insurance, and patients really love it because it's easy. It doesn't seem to interrupt their sleep quite as much. Another exciting technology, which is a little less mainstream at this point, but I think soon to become, is cardiopulmonary coupling. So these are devices like the Oura Ring, for example. I put $sign there because this is not really covered by insurance as of yet. I believe it probably will be in the near future. And so patients usually have to pay per night of the study, something on the order of $150 or so. But cardiopulmonary coupling, again, uses that cardiac and pulmonary relationship to help diagnose obstructive events and look at sleep stages. So it uses spectral analysis and kind of proprietary algorithms looking at respiratory tidal volumes, heart rate variability, that can then tell you if this patient's in stable or unstable sleep and whether they're in dream sleep or REM sleep versus non-REM sleep. So some pretty exciting stuff. You all might have this on your watches or have seen patients or have patients come to you and say, but look, I'm getting terrible sleep. Take a look at what my watch says. And the truth is that the wearable devices on some of these mainstream devices, it's some good data, truly. And a lot of it is using some of the same those same cardiopulmonary relationships to help look at, is this person in dream sleep, like REM sleep? Are they awake? Are they in deep sleep, et cetera? These data are not validated, so unfortunately we can't make diagnoses of obstructive sleep apnea based on these data, but I definitely review them, and I think that they're kind of valuable pieces of information when patients do bring them in. So we've talked about diagnostics. Now just a word on kind of treating sleep apnea. And so, of course, some of the benefits are going to be obvious to treating sleep apnea. Patients will get symptom relief. If they're, snoring and having a tough time in their marriage because of it, this could be helpful. And then I certainly see some patients who, treating is a must for safety for others, school bus drivers, pilots, and things like that, to make sure they're getting restful sleep. But there's kind of this group of patients that it's a common referral base, and patients may wonder, if they have cardiovascular disease, if they have high blood pressure, diabetes, or if they're trying to lose weight, will treating their sleep apnea help them? And in fact, I get some patients that come to my office and say, I don't know why I'm here. My cardiologist told me to come. And the truth is, we don't really have great data that shows that treating sleep apnea curtails the, changes mortality or, improves morbidity or mortality associated with these disease processes. We know we can improve hypertension to some degree. We know we can improve diabetes to some degree, but not to the extent that current medications available can. While obstructive sleep apnea often is comorbid with these conditions, the data just isn't there to say that definitely, we make a huge difference with these outcomes with treating sleep apnea, but some of that is the data's fault. Pathophysiologically, for patients who do have cardiovascular disease or risk of, the guidelines do recommend that we treat obstructive sleep apnea pretty aggressively in these patients to hopefully prevent worse cardiovascular outcomes. So which kind of provider should treat sleep apnea? Well, I'm a little biased here, of course, as a sleep specialist. Obstructive sleep apnea often has company, meaning patients may also present with insomnia, restless legs, circadian rhythm issues. And so there definitely are sleep medicine specialists who specifically have been fellowship trained, board certified in sleep medicine. Pulmonologists may be a part of this group, also neurologists, psychiatrists. There's lots of sort of different feeders into this field, but we do rely on ENT specialists and sleep apnea dentists, particularly for kind of those mechanical obstruction issues, to help as a part of patients' care. And so you may run into specialists within these fields that specialize in sleep apnea and may also be kind of part of your care or patient's care. So overall, I'll say it's a really exciting time to have sleep apnea. I know no one wants it, but if you do have it, things have really gone well for the field in the last decade. We've got better masks, better machines. Some of you may have heard about kind of this new therapy called hypoglossal nerve stimulation, which is really exciting because aside from CPAP therapy, it's really kind of the only other kind of approved option for patients with severe obstructive sleep apnea who have failed CPAP. Essentially works like a pacemaker for the tongue. So this is an exciting, potential offering for those who qualify. And then coming down the pipeline, not quite approved yet, there's, likely going to be medications to help address these issues with pharyngeal dilator dysfunction, and some really exciting data coming out about this. So overall, I hope I've shared my excitement over this field. I thank you all for listening.
Want to thank all of our panelists for their interesting presentations. Remember, if you have a question for any of our panelists, you feel free to type it in the Q&A box, either on the top or the bottom of your screen, depending on which software you have. And a lot of questions have come in already, and you got some tough ones for our panelists today. Let's start with asking Dr. Liu to join us on the screen. Dr. Liu, we've got a mixed, I suppose, ethical capitalism question for you to start out with. Let us assume that you are an employer of large numbers of employees, and you've got a benefits plan, including health insurance and prescription coverage. What the question asks is, do you have a moral obligation, an ethical obligation to tell your employees, hey, you might be able to get your drugs cheaper from these online prescription providers than from your company we do business with? And two, hey, maybe as an employer, it'll cost me less for drug costs if they use these companies, because some of these companies say, we don't even involve your insurance company. We sell the drugs so cheaply, we never invoke your insurance, and therefore, as an employer, I might be saving money. What do you think about that complicated set of questions?
Dr. Halperin, that is indeed a very complicated question. And to address the first question, whether if I were employer, we're obligated to offer, to inform our employees of these discounts. I believe we should, because ultimately, we need complete transparency and disclosure of the offers or benefits available, and that includes discount if appropriate. Now, as far as the second part of that question, in terms of the financial benefit perhaps of the employer, I think that should be disclosed as well, because they need to understand that it's kind of like when you present for, let's say, the CE, we need to disclose whether we have any conflict of interest or not. It's beneficial to you, but I got to disclose what my benefit is to me, if anything, financially or not. So I believe the answer to both would be yes, ethically. Thank you.
Okay, well, stay with me for a minute. There's going to be a but here, right? I mean, we know that some of these online providers of drugs have been making their money by selling patient information. People are getting their information bundled up and sold so they know how much of this drug they're selling in this zip code, which physician's writing for that one, and what the patterns are. They're not making their profits necessarily on selling you a prescription for $3 a pop. They're making their profit by selling your data. So what about that?
Right. So that's also a great point. And again, maybe I'm being a little overly ethical, but I think, transparency is very key. And I don't mean hiding behind a bunch of paragraphs written by legal, which no one reads, right? Everyone just signs off saying, okay, I agree to this third-party agreement of disclosure of information. I think that we need to let them know that here's some benefits. However, here are some potential things to be aware of, potentially your data being sell off to others. So I think the transparency is very crucial regardless. Great question.
Okay, as a consumer, you have any suggestions for a consumer before they sign up with these companies to find out, hey, are you going to be selling my data to someone?
Yes. So I think the biggest thing is, you need to market, you need to do research of the company you're going to be dealing with, understand their history, their value, but also see if there are any data breaches done before or how they use their data. If they were transparent and you found something, obviously you will know what to do. However, there are companies that don't disclose it easily because they're not necessarily required to, at least not obviously disclose it. So you need to really decide to yourself, is let's say, the extra $10, $15 you save on per prescription really value the data? It's kind of like the same thing with DNA testing. Do you really want to potentially sell that data off and have some ramification down the road? So as a consumer, we need to inform you with the best information possible, and then you need to decide as a consumer whether to proceed or not.
Well, thank you. As you've been talking, one of our attendees has written in, hey, you didn't talk about direct counseling by pharmacists. Is that really important? And is it going to be lost if you're getting your prescriptions online and coming to you in a plastic package in your mailbox?
That's a great question, Dr. Halperin. And patient counseling, as all of us know as healthcare providers, are required by law, especially for new prescription or prescription changes. For mail order, like you said, Dr. Halperin, well, just drop it off and call it a day. According to Medicare, Medicaid, the requirement for mail orders, you must provide a toll-free number, and also you must provide minimum business hours or even business days, depending on the state's jurisdiction. So you might need to offer, let's say, Monday to Friday, 9 a.m. to 9 p.m. Eastern time. That will fulfill the counseling requirement.
All right. Well, while we've got more questions for you, we're going to give you a break to catch your breath and let you off the hook for a while. But we're going to bring Dr. Soffler on. We've got some questions for her. I gotta go with the first one from my sister, Dr. Salfler. She wants to know, how in the world do you expect anybody to get a normal night's sleep and valid data in your fancy schmancy sleep lab with all those wires attached to them? Nobody could possibly sleep with all that stuff attached to them, can they?
Yeah, that's a great question. And it's a concern that a lot of patients have when they come to see me, and I recommend that they go to the sleep lab. You're right. We don't expect patients to have their best night's sleep when they come to the sleep lab, and we tell them to do their best and try not to have anxiety about it. It's definitely not a natural condition to sleep in. They're all hooked up to all of these wires, and then we say, all right, now go ahead and show us some sleep. But the nice thing about an in-lab sleep study that's different from a home study is that the EEG leads that we can apply during an in-lab study allow us to look at only the time periods of the night where the person is actually asleep. So even if it's a short period of time, if we're getting at least some sleep, we can often make some diagnoses about sleep disordered breathing or sleep-related leg movements. In a home sleep study test, your breathing might look great, but maybe you weren't sleeping. So that's kind of the caveat there. Thanks so much for that question.
Well, stay with me for a minute. We've got an equally feisty question. You people are always talking about machines and technology. She spoke and didn't say a word about smoking cessation, weight loss, or alcohol to keep from having to see her in the first place. So why aren't you talking about that instead of all your exciting times to have sleep apnea because you got new machines?
It's a great point. It's a great question. And I certainly do not want to dismiss the importance of weight loss, avoiding sedating substances at nighttime, such as alcohol or, other drugs. And those do remain an important, what I call adjunct to the management of sleep apnea. And for mild sleep apnea, where there are fewer events or kind of more mild obstructive events, sometimes those changes by themselves can make a difference. But for some people who have moderate, to severe sleep apnea, again, those are sort of adjunctive things that may help alleviate some of the symptom burden, but oftentimes are not enough to actually completely cure the sleep apnea.
Well, thank you. But as you've been talking, one of our attendees has been furiously typing away, asking you, if someone exhibits snoring, loud at times, soft at others, but no obvious signs of apnea, such as stopping, breathing, gasping, do they still merit testing for apnea?
It's a great question. I would, it depends a little bit upon who the person is and what other, how they view their sleep overall. For just snoring that's otherwise not impacting your life, if you're otherwise healthy and don't have some of those other cardiovascular risks that I spoke about, as long as your marriage is okay, or your spouse, your partner is okay with the snoring, it's okay. It's probably okay to monitor that. I would say snoring in somebody who has a lot of other medical issues, particularly cardiovascular issues, should, prompt you to get evaluated by a physician to say, or a clinician to say, should I have, further testing for sleep apnea? And then your clinician might use other hints in order to, to determine whether or not your pretest probability is high enough to go for a sleep study. Do you have a large neck? Has there been recent weight change? Are there other things that might make you predisposed? So thanks for that question.
The same questioner is also asking you, is there a relationship between apnea in women and the onset of menopause?
Oh, that's a wonderful question. There absolutely is. Hormones tend to be a little bit protective for women in terms of their development of obstructive sleep apnea. We see obstructive sleep apnea develop more frequently in men, and that's more frequently at an earlier age. But come sort of in the postmenopause period or perimenopause to postmenopause period, that risk equalizes in a lot of ways. So in addition to being at risk for obstructive sleep apnea, I see a lot of women in the perimenopause and postmenopause period who have significant sleep disturbances otherwise too, that are kind of interrupting sleep and may also affect their breathing stability at night. So thanks for that question.
No, thank you. We're Gonna let you take a rest, and as they say in the game show world, Anitha Srivanasan, come on down. We got some questions for you. Anitha, our questioner wants to know, the doctor said that elderly women are often found on autopsy to have DCIS, and it had no effect, the doctor said, on patients during their lifetime. Does that mean you should stop doing mammograms in these women to look for a diagnosis you're not going to do anything about anyway? What are you getting the mammogram for in the first place?
Thank you for the question, Dr. Halperin. It's an interesting question, irrespective of DCIS as such. I was just giving that as a perspective of how we found the disease. And a lot of times it happens to be an incidental finding, which led us in the late 20th century to finding what DCIS is. But it doesn't mean we don't screen patients or avoid screening in certain patients purely based on age. So increasingly, the US Task Force, NCI, a lot of the bodies do have an upper limit on screening, at least when they quote their studies and findings. Usually you will find large breast cancer studies start with screening being 40 to 80. US Task Force being 75 as the upper limit of mammo. That doesn't mean the minute you are 76, you have to stop screening. It still is a cancer. It could be an aggressive cancer. It could lead to death. So what we as clinicians, just like in every other field, practice is making a clinical judgment based on functional age. If somebody is very functional and productive and is able to withstand a mammogram, we will continue screening them after a discussion with the patient. But yes, the data is less and less on elderly patients and screening. DCIS as a disease doesn't change its course or the fact that it coexists or can coexist with invasive cancer just because you're older than 75. I hope that answers the question.
Yeah, it does. There's a related question here, Anitha, which is, if DCIS is often diagnosed in the United States on screening mammography, is this less of an issue in less economically developed countries? Is this discussion that we've just had a peculiarity of wealthy countries where there's a larger penetrance of mammography?
Thank you for that question. It's a very interesting question. So we in the breast cancer world and overlap of public health, we tabulate countries as low, intermediate, and high resource countries, according to BHGI or Breast Health Global Initiative. In the low resource countries, we are focusing more on actually finding early cancers that are even palpable, increasing awareness. So it all depends on what's your resource. Likely, there is not as much resource in a developing country, which is cash-strapped, to screen patients every year, and the patient compliance is also low. That doesn't mean there is less disease or it's less prevalent because of where the country is geographically. We have not seen a geographical correlation saying this part of the world has this and this part doesn't. It is more an economic correlation and a resource correlation that defines when you find DCIS. Because remember, this condition is almost always diagnosed on imaging. So the frequent imaging and screening will, of course, detect more disease. Thank you.
Thank you, Anitha. We're gonna give you a break now because we've got a long list from Marissa Montecalvo and we'd better cover some of them. Marissa,
Hi.
our questioner wants to know, aren't there ongoing trials of the RSV vaccine in younger people, diabetics, asthma patients, children? Are there likely going to be new approvals for RSV in the next long season?
Yeah, thank you. I am aware of data being reviewed by the American College of Immunization Practices for the 50 to 59-year-old age group. And I think that's the next age group that's going to be looked at. I am not aware of more of other studies. And also Moderna is also developing an RSV vaccine. That's back at the 60 or 65 and older. So I'm sure those data will be reviewed as well. I just want to circle back a minute. In my presentation, I had spoken to you about shared clinical decision-making. So the original recommendation when ACIP, the American College of Immunization Practices, met last June, the original thought was that for 65 and older, it should be recommended, whereas the 60 to 64 would be under shared clinical decision-making because the efficacy wasn't as high. But somehow by the end of the meeting, it became shared clinical decision-making for everyone. So I think the next steps are to reevaluate that. And yes, there are data that are in process for 50 to 59, and that will be looked at as well.
Thank you. Another questioner has typed in, I didn't hear anything about recommendations for RSV last year. Have there been changes or updates since then? When did this all happen is basically what they're asking.
Yeah, thank you. I should have been clearer on that. So it's all this season because the approval of the vaccine for older adults, for the 60 and over, was actually, the FDA approval was in the final days of May, I believe. Then it went to the American College of Immunization Practices and the recommendations came out in late June. So this is the first RSV season in which there's a recommendation for vaccine.
Okay. And another question for you is, the questioner writes, my internal medicine physician told me that this RSV vaccine is, quote, a lot more immunogenic than some other vaccines, close quote. It produces a brisk immune response. Does Dr. Montecalvo agree? And if so, should people with diseases like rheumatoid arthritis or multiple sclerosis, autoimmune diseases, be more wary of this vaccine?
So thank you. I think there are two questions in there. So the first regarding just, is the immune response brisk, occurring more quickly than, let's say, for COVID vaccine, right? Something we're all familiar with. I honestly do not know the answer to that. I don't recall seeing that. I didn't look into that very specifically. The Pfizer and the GSK trials do have an arm where they're testing antibody levels, but you're talking about how quickly. I would have to look into that. But the second question, which is very important, is if there were any issues, what happens to the person who has an autoimmune disease, right? And how should they approach this? And I want to be very clear about that anyone who has an autoimmune disease should be discussing their risk with the physician who is taking care of that disease. The treatment of autoimmune diseases is so complicated these days with relation to immunosuppression, biologics, and what is the best role for immunization and at what point is really something that you want to be talking with someone whose specialty is in that area for you.
Okay. Well, your slide, Marissa, of the dramatic slide of the person sneezing got one of our attendees interested because you mentioned, oh, this virus can live on surfaces. They want to know if we're back to 2020 where they need to get out the Lysol and start scrubbing the Amazon packages before they bring them into the house, wiping down the can of green beans from the supermarket and cleaning the surfaces in the kitchen counters because Dr. Montecalvo says this virus can live on surfaces.
I love this question. This is a great question because it gives me the opportunity to say that I think you should have never been wiping down Amazon packages nor your green bean cans, but you should be washing your hands. So it has an environmental reservoir. If you have a child home who's sick with RSV, if you're in a hospital and a child has RSV, you're asked to wear gowns. So in that situation, you would be careful about surfaces that you're in regular contact with, but hand washing is key. But in general, it's really, when you're touching things, you just, whatever you're touching, if your hands are going to be close to your mouth, or you're eating, or you're going to be around your nasal mucosa or your oral mucosa, you need to have clean hands. And who knows where those Amazon packages have been? You should always wash your hands after you pick up those Amazon packages.
Okay. And what about this vaccine and child care workers? The pediatrics, children's hospitals are filled with children with RSV. Should we be expecting daycare center workers, et cetera, to be vaccinated?
So that's a really excellent question. So it's not the adults who are giving it to the children for the most part, right? It's the children who are the main reservoir of the infection. So I think I have not seen data looking at trying to tease out occupation out of the age groups in which they're looking at this. So I don't think the data are there yet. I mean, I can understand why that comes up, but I think it's not that working in daycare puts a 30-year-old adult at such high risk. It's really, what is the risk based on age, I think, more so.
Well, thank you. We're going to turn our attention back to Dr. Liu. Thank you, Marissa. Dr. Liu, this is my question. This morning, having had the chance to look at your slides in advance, I went into the medicine cabinet and started looking at over-the-counter drugs. Omeprazole, famotidine for heartburn. Order them from Amazon. Box comes, says made in India. I started looking at all the things in the house that were purchased at CVS or Walgreens or Duane Reade. Doesn't tell you where they're made. It just says it's got the name of the corporate headquarters of the chain pharmacy for all that over-the-counter stuff we all have in our house. You showed a pretty concerning slide about tainted prescription drugs from Canada. Now do we all have to worry about, my goodness, where's all this stuff being made, and how do I know that my acetaminophen actually isn't tainted with somebody? I don't know where it's made. What are we to think about that?
So Dr. Halperin, that's a very hot topic that doesn't have a 100% clear resolution. So essentially, the first step is, be aware of the source of the pharmacy you're ordering from. If it's a larger, so-called chain pharmacy or large corporation like Amazon, CVS, Walgreens, there's a good possibility they may be purchasing not just prescription, but over-the-counter from quote-unquote better, reliable sources of distributed. Now, the manufacturer you mentioned is a good point. It's a lot of them are foreign source. So if, let's say, we buy from a certified registered pharmacy by the state, we still don't feel confident. The next step is really to call the manufacturer directly. And oftentimes they should be able to ask you questions, let's say the lot number, to see whether it is contaminated or whether it's reliable or not. Now, if let's say you call the manufacturer in India, there's a good possibility you may not reach them, or they may not even pick up. What is the last source of defense to verify the quality and to be certain of the integrity of it? There's really not a good answer. The FDA has various independent labs and federal labs that actually are conducting random batch testing of generic companies, including over-the-counter, to check for impurities, to check for if there's certain levels of unacceptable toxins, again, from random batches from that generic company. There's a vocabulary for it. It's called the Cooperative Research and Development Agreement, CREDA, along with the FDA and Department of Defense. So that is underway as far as like checking the credibility of these generic companies. Now, is that data readily available for every generic company? Unfortunately, the answer is no. So that's it's kind of like a work in progress answer.
Oh. Thank you. We're going to turn to Dr. Srinivasan for our next work in progress question. The questioner writes, if you're really not sure which DCIS case is going to progress to invasive, then isn't this a problem crying out for molecular diagnostics to predict transformation? And also, you talked about which patients with lumpectomy might not need postoperative radiation. Shouldn't there be molecular diagnostics to help with this prediction?
Question, thank you for the question. So I'll take on the radiation first because that's easier. Not all the cancers require radiation. We kind of are closer to an answer in that realm because we do use molecular technology. We use precision diagnosis or precision DX that can score. And we also look at histologic features, the total size of the tumor, as well as other risk factors clinically in the patient. And we do tell patients that you may not need the added benefit of radiation, which in a very small DCIS with low risk factors or low grade is going to prevent recurrence and not as much survival. So radiation, so we make sure that we tell the patient that they understand they have a very low risk for recurrence anyway, based on the size, based on the histologic features. And yes, there are molecular markers, but even without the molecular markers most of the time, you can arrive at the diagnosis and it's a discussion with the patient. That's a little clearer. However, the part where not operating at all and observation is still out for question. There are very, very robust trials, which include the PREDICT trial, the COMET trial, the English LORIS trial. All of these are looking at observing patients who technically have low risk features in their DCIS. The problem is there's not one magic bullet that's able to give us clinicians an answer as to proceed with surgery, observe this patient. We just know if it has low risk features, we can wait a little bit. It's not going to evolve into an invasive cancer overnight. We can continue imaging and so forth. But then you have to be honest with the patient and tell them, this is what I found. And 20% to 25% of the time, there is coexisting invasive cancer in a DCIS biopsy. All comes DCIS, not necessarily the low risk, but all positive DCIS can have coexisting 20% of invasive cancer by just purely sampling locations. So if that's the case, add that to the 10% that you have very well biopsied, you're pretty confident there is no invasive, but are going to progress somehow to invasive. And then there is the fact that you may have missed it because of sampling error, and you then don't have one molecular testing. And you have to put all of it together and then come up with an answer saying, you don't need surgery, we'll observe you. Like I mentioned, University of California, San Francisco has a trial called the COMET trial where they are deciding this with patient discussion, and they're actively looking into it. And there's some centers have adapted it much more than others based on their patient population, their ability to get the patients to surveil very, very closely. Thank you.
Thank you. Thank you. We're going to give the last word to Dr. Sothler. Our questioner is curious about your diplomatically constructed slide about ENT doctors and dentists participating in the care of these patients. Should anybody be fit with these appliances if they haven't had a sleep study? there certainly are advertisements saying snoring, come to see such and such a dentist and we'll fit you with an appliance. And they doubt that those people are being sent for any studies with EEGs, EKGs, and peripheral oximetry. What about, well, I'll just fit you with an appliance?
Right. So when we talk about treating obstructive sleep apnea with an oral appliance device, we're talking specifically about a personally fitted device that brings the jaw forward. So this is something that needs to be personally fit and isn't something you could purchase over the counter. And for that reason, really, even to get it just covered by insurance, you're going to need actually to have a sleep study and to have a formal diagnosis of obstructive sleep apnea on a sleep study, whether that be a home study or an in-lab study, to get that paid for by insurance. And the out-of-pocket cost could be in the thousands, actually. Even with the sleep study, sometimes the insurance companies will often balk at kind of paying for those devices. So,
doesn't this lead to the obvious question? Yeah, but there's commercials on television. Buy this nose strip or this insert into the nose, and it'll take care of your snoring.
Yeah, so those devices are a little bit different than the oral appliance devices. And I do use some of those, quote, over-the-counter types of devices for patients who have mild obstructive sleep apnea, where if we can just give them a little bit of airway pressure by kind of blocking off the nose or having kind of a one-way valve through the nose, can we treat some of that more mild obstruction? And so for some patients, it's a great option. You don't necessarily have to have a sleep study for those devices, but you often do need a prescription. But we refer to those as like EPAP devices or external pressure devices.
Yeah. Well, thank you, Dr. Seltzer. I invite all of our panelists to come back on the screen. We want to thank you for joining us for today's webinar. And members of our audience, we will see you next time with more information from these webinars from New York Medical College and Touro University. Depending on where you are in the world, have a good morning, a good afternoon, or a good evening. We'll see you next time. Bye, everyone.